Good evening, everyone. The session will start in about 4 minutes. Thank you. Good evening, everyone. The session will start in about 2 minutes. Good evening, everyone, and welcome to day 2 of the Lumenis 2020 Dry Eye Summit. On behalf of our panelists and everybody here in Lumenis Ophthalmic, I would like to thank you for joining us for one more day, one more night. We hope we're going to give you a very informational program and some exciting sessions coming up. We also will want to thank everybody that actually visited us yesterday in our launch of the virtual booth. We had some very interesting live chat conversations. Again, please remember we have sent you a link that you can visit our booth at any given time, and you can interact with each and every one of us live on real time. And we also welcome you to interact with the systems and download content from inside the booth. Also, we have a surprise for tonight at the end of the session. In the spirit of the holiday season, we're going to give out some presents. All you have to do is pay attention and answer the Lumenis quiz at the end of the presentation. We have some very interesting guests tonight. Dr. Nicolás Alejandre Alba from Spain, from Jiménez Díez Hospital in Madrid, will be talking about the importance of osmolarity in the diagnostic pipeline. Dr. Nicolás Alba is in the head position in the research and development in his hospital, and also he's an ophthalmology supervisor and member of the institutional review board in Spain. And our next guest doesn't need any more introduction. This is Dr. Rolando Toyos. Dr. Rolando Toyos is the father of IPL for dry eye. He's been working with this technology for the last 22 years. He will be talking to us about advanced IPL treatments. Those are treatments that do not confine only to MGD, but you can actually see very good efficacy in other treatments as well. He will also introduce us to some techniques that he's working on. So without further ado, I'll give the floor to Dr. Nicolás Alba. Thank you.
Hi, this is Nicolás Alejandre, head of Cornea and Ocular Surface Department in a university hospital in Madrid. And I want to share with you some facts about tear. First of all, as you all know, 3 years ago, due to establish hyperosmolarity of the tear and the ocular surface as a key point in the development of the dry eye disease. In fact, as you can see, it was established as a hallmark of the disease. In this classic scheme, we can see how it plays a central role in the pathophysiology and development of dry eye disease. But what is tear osmolarity? Tear osmolarity is a measure of the solute content of the tear film. It is also a biomarker of ocular surface health, and when it's altered, it indicates that there is a breakdown of the homeostatic equilibrium in the ocular surface. Abnormal osmolarity is defined by osmolarity greater than 300 milliosmoles per liter, or when the inter-eye difference is greater than 8 milliosmoles, indicating instability of the tear film. As you can see, it starts below normal subjects, normal patients have an osmolarity below 300, and from that it starts a mild dry eye disease, which turns into severe disease around 340 milliosmoles. But can we measure it? Let's talk about Tearlab. On the bottom of each test card is a gold lab in the chip, which is the heart of the Tearlab system. This is where nanofluidic samples of tear fluid are collected and analyzed in conjunction with the electronics contained in the pen. The pen and the test card combination is actually the analyzer, allowing 50 nanoliter samples to be measured and analyzed. We must remember that we must avoid anything that will alter the tear of the patients 2 hours prior to Tearlab testing, including tonometry, ocular surface staining, measuring the shimmer, or using the slit lamp. You can test patients with contact lenses in their eyes if it's necessary. Although the Tearlab allows simple tear collection, certain cautions must be followed to ensure effective collection. First, sit the patient with their head tilted back and looking upward and away from you. Collect the sample of the margin of the lower eyelid, and do not pull the lower eyelid from the globe, and this will reduce the tear meniscus height and may prevent their tear collection. Tear collection should be taken at the lateral tear lake to avoid inadvertent corneal contact, and the tip should be lowered onto tear meniscus. Remember that every study with Tearlab has been performed taking samples from this site. If you use another site, the numbers may not be applied to your practice, because we have no real knowledge of what's happening in the nasal size of the tear meniscus. Remember, avoid touching the globe, as you may hurt the patient, and it causes a reflex of tearing or scratch in the eye. But why measure tear osmolarity? The question should be, do you believe in these two or not? Because if you believe the suggestions made by that group of experts were right or were worth considering, you already know that you need to test every patient with a standardized questionnaire about their symptoms. And then to make the diagnosis of dry eye disease, you should have one out of 3 of the main signs, which are non-invasive tear breakup time under 10 seconds, altered osmolarity, or ocular surface staining, whether in the cornea or the conjunctiva. Then you will go on with your diagnosis and try to establish if it's mainly an evaporative dry eye disease or aqueous deficient dry eye disease. So if it's important to make the diagnosis, we will always be asking if it's precise. And yes, it is very precise. It's even more precise than fingerstick blood glucose testing or fingerstick cholesterol testing. And it's also predictive, because the positive predictive value of measuring both eyes once, it's 89%. It goes up to 100% if you measure both eyes 3 times. But FDA has concluded that doing it once has a good enough positive predictive value. Here, for example, you can see 2 patients from a study, and you can see how patients with, here there is a patient, this is a dry eye disease patient. You can see how there is a lot of variability in the measurements in the same day, just 4 minutes from separating the measurements from eye to eye and from day to day. But in a normal patient, you can see that measurements have a very, very, very small variation. So it's not the test that it's very variable, but the disease, dry eye disease, is characterized by a great variability in tear film osmolarity. With the time, we have learned that the higher or the more severe the dry eye disease, the higher the osmolarity, the higher the variation we will find. But also, it can be very useful when you have a normal test in a symptomatic patient. Here we can see a study performed some years ago, a prospective observational study with of 50 patients with one or more symptoms of potential dry eye disease, but normal osmolarity. As you can see, most of them had something else, but they didn't have dry eye disease. So when you find a normal test, remember that's probably the patient has a different thing from dry eye disease. And still, but apart from the diagnosis, will it be helpful to measure tear osmolarity? I think it will help us to manage the treatment. You can see how in this study, how this is an in vitro study where epithelial cells were exposed to 24 hours different levels of osmolarity, and you can see in the absence of inflammation, just hyperosmolar medium will stress cells and kill them. So reduction in hyperosmolarity is critical to alleviate corneal epithelial stress. In this recent study, you can see how dry eye disease progresses with age. So in the third decade, we can start finding meibomian gland dropout and alterations of the lipid layer. Around the fourth decade, tear osmolarity starts growing, and there is some dry eye symptomatology. But not until fifth decade, the tear meniscus is altered, and we will find conjunctival staining. Of course, this is the proportion of participants showing this thing. So you may find some dry eye disease patients with corneal staining at the age of 25. But this is a global perspective of how it progresses. And corneal staining typically doesn't appear until the sixth decade. And if we see a patient with altered tear osmolarity, whether because it's high or because interocular difference is high, around 37 years of age, this is predictive of continuing worsening dry eye disease. So when the tear osmolarity is altered, remember you and your patients have a great interest in making it normal again. Tear osmolarity, if left undiagnosed and untreated, tears will become increasingly cytotoxic to the corneal epithelium, and death of the two superficial epithelial cells expose and the underlying immature cells to the cytotoxic hyperosmolar tears, and then we will see the cycle restarting again with the death of those immature cells, making the dry eye disease worse. But you can see not only diagnosis and prognosis are improved with measuring tear osmolarity, but also it will help us to manage the therapeutic response. This is an example of before and after tear osmolarity, before and after treating the patients with high dose of omega-3 fatty acids. And you can see how the symptoms improve after with treatment, and also the osmolarity improve, and there is a statistically significant difference between the placebo group and the treated group. And same happens with cyclosporine, HPA tears, and this we have already talked about. So it will help you to customize and follow the treatment of your patients and explain them if it's working or not. Same happen with visual function. When a patient has a normal osmolarity, the scatter of the tear is very small and visual function is good. But look what happens in a patient with high tear osmolarity. There's a very, very big fluctuation with blinking of the scatter of the tear film, and how it improves when you're instillating an artificial tear, and how it's very, very stable after 15 minutes of installation. So tear osmolarity is also a measurement of how the visual function of the tear will be doing. But if the tear film is stable, when you use a device that needs a stable tear film to make their measurements, they will be very variable, and that's what's happening with our keratometry readings in dry eye disease patients. They have a very big fluctuation of the stability of the tear because of their tear osmolarity, and your measurements will be very variable. Here you can see the bigger the osmolarity, the more dispersion you have in your measurements, and how normal eyes will be more or less around 1 diopter of variability, even less. But you can find in severe dry eye disease up to 3 diopters of variability in some patients. So 17% of hyperosmolar eyes had more than 1 diopter change when you're measuring the keratometry values of the cylinder. And also, you will find that if you're using Tearlab osmolarity testing, your patients will feel that you're doing more for them. 93% of patients reported that knowing their osmolarity helped them to understand the severity of the disease and the effectiveness of the treatment. 87% said knowing their tear osmolarity helped them to better understand dry eye disease. And 83% of patients said that tear osmolarity testing gave them more confidence in their doctor. And here we have summarized some of the clinical takeaways. Osmolarity is an important biomarker of the ocular surface health. Abnormal osmolarity indicates an unhealthy tear film, which can potentially damage the ocular surface. And it is defined by being greater than 300 milliosmoles per liter, or when the inter-eye difference is greater than 8 milliosmoles. If tear osmolarity is normal in asymptomatic patients, find an alternate diagnosis. It may not be dry eye. Tearlab is precise and predictive. Variability is a hallmark of dry eye disease. Tear osmolarity measurement can help in your diagnosis, prognosis, and management of the therapeutic response. And abnormal osmolarity can have an impact on your pre-surgical measurements and influence your surgical outcomes. And remember again what said Deus 2 about a marker. It should play a direct role in the pathogenesis of the disease, significantly improve upon treatment with an effective therapy, with the best markers traversing a large dynamic range, and be specific of dry eye disease. I think this is they were thinking about osmolarity when they wrote that paragraph, because that's exactly the things tear osmolarity is doing for us. Thank you very much, and I hope to see you and hear you in the question time we will have now in several minutes.
Thank you, Dr. Alba. The Q&A session will be hosted approximately in 45 minutes to have both Dr. Alba and Dr. Toyos on the line together. Before moving to Dr. Toyos' presentation, we want to engage you with one poll. We want to ask you, How often do you use osmolarity test? You can see in the screen as a part of your diagnostic pipeline. Here you have the results.
Okay, this is interesting. So not too many of you are actually using osmolarity. So that would be a good topic to discussion in the Q&A. We can ask Dr. Alejandre.
Hello, Dr. Alejandre, can you hear us?
I think he's going to come up later. Let's move on to the next presentation then.
Okay, yes, we're having now Dr. Rolando Toyos talking about the Optima IPL.
Hi, I'm Dr. Rolando Toyos. We have clinics in Nashville, Memphis, and New York City. I'm going to be presenting the Lumenis Optima intense pulse light system in your clinic. I tell people that I'm a cataract surgeon, LASIK surgeon, and a dry eye specialist. On the screen, you see the book that I published, Dry Eye Disease Treatment in the Year 2020. I wrote this and published it years ago, pushing out to the year 2020. I was expecting big things in the year 2020. I don't think any of us were expecting what happened with COVID. But actually, COVID kind of rolls into my talk. And the thing that I had written a book, and I was working on a book on healthcare when the pandemic hit. So I actually incorporated a lot of things that were going on with COVID into my book. And this is available on Barnes & Noble and other things. But what's important in terms of IPL, and this is something I've been talking about for a long time, is that intense pulse light is being used to fight COVID. So there's these things called Xenex robots, and these Xenex robots actually are placed in a room in a hospital, and intense pulse light is shot out there. And what the intense pulse light does is it actually kills all the microorganisms in that room. So this robot rolls around the whole room, flashing this light and killing these microorganisms. And this is one way that here in the United States, we're combating COVID by disinfecting our rooms with intense pulse light. So for years, I've been telling people that one of the reasons that intense pulse light works and one of the mechanisms of action is that intense pulse light actually will kill the bacteria and Demodex that are on the eyelash margin, which will decrease the bacterial load. And actually, as we know, that bacteria and blepharitis go hand in hand with dry eye. The more blepharitis you have, the more dry eye you have. The more dry eye you have, the worse your blepharitis gets. One thing to note about this segment that I'm talking about is that actually, when we're talking about Demodex, a lot of people get into this thought process that Demodex is just at the eyelash margin. But actually, you have Demodex that are on the whole face and on skin. And Demodex seems to migrate towards the lid margin. And the reason why they do that is around the hair follicles. You have a lot of dead skin, a lot of oil that these Demodex can actually eat. So one of the good things about doing IPL around this whole area of the face is that when we're doing treatments, I tell people go ear to ear, is that the IPL will kill not only the Demodex that are on the lid margin now, but Demodex that is around the face that will migrate towards the lid margin. I said before that I'm a LASIK surgeon and a cataract surgeon, and I tell people all the time, and doctors all the time, is that if you're any of these things, if you do cataract surgery or LASIK and you're not treating dry eye, then you're actually missing out. A lot of your patients, a smaller percentage on the LASIK side, but a high percentage on the cataract side, have dry eye. And as we know, if you don't correct dry eye and the ocular surface before you do surgery on these patients, that these patients won't do very well. So the prevalence of dry eye is increasing. I'm seeing it more and more in our practice, more patients, mild, moderate to severe in our practice, because we're seeing younger and younger patients with it. So if you're not seeing dry eye in your practice, it's just that you're not looking for it. And if you're not a dry eye specialist, even if you're a glaucoma doctor, a cataract doctor, a LASIK doctor, any of these things, if you're not treating these dry eye patients, you're not getting the best results possible. In terms of this prevalence and how it's increasing, I'm seeing younger and younger patients, and the reason why I tell them this, that we're seeing this increase, is that we're, especially in the time of COVID, we're on screens all day, you're doing Zoom calls. If you watch me during the Zoom call, you'll probably see that my blink rate is really low. And that, and when we're doing things like looking at a screen or watching TV or looking at our iPhone, what happens is that decreases our blink rate, which leads to more dry eye. And if you look at what's happened to the diet, and this is internationally, is that our diet is getting worse and worse. We're taking on a more inflammatory diet, and eating less vegetables, eating less omega-3s, and are getting a lot less omega-3s into our diet. So that's also contributing. So one of the biggest jumps in dry eye is young people who are on their phones and on computers all day, and who are not getting adequate nutrition. And then, and this is what we were discussing before, you don't fix the ocular surface that is responsible for a big portion of our visual acuity, you're not going to be seeing well. So one of the number one signs of patients having dry eye, and it might be the first sign when they come in, is they just aren't seeing well. They'll complain, oh, I don't know what it is. As the day goes on, my vision gets worse. And that could be the first sign, as opposed to, oh, my eyes feel dry, or when I'm blinking, I have something in my eye. What is the most common dry eye is evaporative dry eye. I think we all know this, that the tear is made up of 3 parts: a water layer, a protein layer, and a fatty layer. The fatty layer is made by the meibomian glands. And one of the things that I try to get doctors to think about is that really this is a skin gland condition that causes and affects the eye. So if these glands, the meibomian glands, and the skin is inflamed, what will happen is you're going to get abnormal secretions coming from this meibomian gland. And then that's what's going to affect the eye. So what we want to do is we want to have treatments that actually treat the lid margin, treat the glands, treat the skin, and to improve patients' dry eye. If you can't improve the glands or the skin, then every other treatment that you're doing is basically temporary and just palliative, instead of having a treatment that will cure. So how I came up with this and found this is that I've been doing IPL for 20 years. And when we introduced IPL into our practice, I introduced it in our aesthetics clinic. And what I would do is I would tell my rosacea patients, we have this treatment that's good for getting the redness out of your skin. It's called intense pulse light. And I would send some patients over, they would get IPL. And then they would come back and they would say, not only is my skin better, I think my glands and my dry eye is better. And then I would look at their glands, I would look at their lid margin, and that was improved. A lot of things that we didn't know back in 2020, or excuse me, a lot of things that we didn't know about 20 years ago, we now know. And one of the things is the reason why we knew that it was helping patients with rosacea is that these patients have abnormal blood vessels that are on the epidermis, and we're applying IPL, it actually closes off those blood vessels. But what we didn't know that it was actually decreasing the amount of inflammatory mediators that are on the skin. And the one inflammatory mediator that I want to direct you towards is interleukin 17. This is a inflammatory mediator that is produced by T cells that produce T helper cells that produce this inflammatory cytokine. What's interesting is that when you apply IPL, you decrease the amount of interleukin 17 on the skin and around the glands, but it also turns out that when you do IPL and you're decreasing this inflammatory mediator, you're actually decreasing this inflammatory mediator on the eye. And it turns out that interleukin 17 is the #1 inflammatory mediator that is the most specific for dry eye. So there's a lot of inflammatory mediators that are made in dry eye, but is most specific that we see. And that actually bears out because if you look at all the medications that have gotten FDA approval, they're all T cell inhibitors. So for example, cyclosporin and lifitegrast have gained approval. So we have here in the United States, we have Cequa, but you've heard of Restasis, and you probably heard of Xiidra. All of those decrease the amount of interleukin 17 because they influence T cells. And that's what IPL does as well. So if you look at all the different medications that have been tried, and we've been involved in many FDA studies, none of the other medications have been approved because they really don't attack T cells. So how I discovered this was these patients with rosacea would come in, I would do intense pulse light, and they would improve dry eye. This is actually the first paper ever written. It was a case study that was published in iWorld way back in, accepted way back in 2003. So that started me on this whole research journey to bring IPL into the ophthalmology space. So here I am applying IPL to a optometrist who has dry eye. So we all have patients that look like this, that they have inspissated glands that are making more like toothpaste-like secretions instead of olive oil. You get thickening of the lid margin. This is something that we actually measure in our office. I think it's a great sign of dry eye. Usually the eyelash margin is going to be right at the level, right below the level of the meibomian glands, not this distance. It's usually a distance of 0.3 millimeters. If you have a topographical instrument in your clinic that measures this, then you could actually accurately measure this distance. So if you have the anterior, we'll measure this for you. Then you have signs of Demodex and blepharitis, bacterial blepharitis, with the dead skin cells on that area, scurf, collarettes. A lot of these patients will start losing eyelashes, and some patients that will be like the first, one of the things that will make them come into your practice to get treatment is these loss of eyelashes. You'll get injection, eventually you'll get injection of the conj, so you'll get a conjunctival blepharitis. And you'll see these telangiectasias. So one of the things, normally you do not have telangiectasias. The great thing about the lids and what we do is, I've got plenty of patients that say, oh, I've never been told I have rosacea. And that's because the epidermis around the rest of their face is thicker, so the telangiectasias don't actually show up. But since this is the thinnest skin of the whole body, you can really see these telangiectasias before you see it in other parts of the body. These telangiectasias, as we were saying before, are actually releasing interleukin-17 and inflammatory mediators. And this is one of the reasons that these glands aren't working, is that you have these inflammatory mediators bombarding the area of the meibomian gland, and the meibomian gland stops working. Now, you don't have to have rosacea or see these telangiectasias to have meibomian gland dysfunction, but it is one of the signs for a skin gland condition. And so it's not only rosacea, but acne patients, you can start seeing this. Acne rosacea patients and other patients with other inflammatory diseases, where you start to see these telangiectasias around the meibomian glands. So what is IPL? So it's not a laser, it's actually a xenon flash lamp. As you can see behind me, that's our periodic table. The whole family, this is our little dining area. Whole family likes to look at the periodic table when we sit down and have a meal. But it's great because it constantly reminds us of the stable gases, xenon, neon, argon. These gases have if you remember back to your chemistry days, they're called the noble gases or the stable gases. So xenon is a very stable gas, and how it works is when you apply electricity to this stable gas, it becomes unstable. But since it wants stability, when it gets back to stability, that releases a broad beam of a broad wavelength of light in a range of anywhere from 400 to 880 nanometers, so blue light all the way to red light. And so what we're doing is we're applying a filter just to block. So if you have my protocol, you know, we're blocking light at around 590 and below. That's because we want red. And at red, and we have done these studies to show this, but actually red stimulates the cells of the meibomian gland to work better in a process that's known as photobiomodulation, and we'll get into that later on. So we have this xenon flash lamp that's emitting light. We put a cutoff filter to block all the wavelengths of light that we don't want. And then, this part is very important when we're talking about the thinnest skin of the body. We actually want to pulse this light and this energy so that we don't give too much energy all at one time to this thin skin. So these pulses allow thermal relaxation time, where you give energy, you stop the pulse, you allow thermal relaxation so that heat dispensation can happen throughout the skin, and then you hit them with another pulse. And so the great thing about the Optimum is it allows us to control all of these things. And we're actually, IPL can give you 10 to 30 joules, but we're working mainly in the 10 to 16 joules per centimeter square. So when applied to the skin, this wavelength of light goes down. And here's one of the mechanisms of action. It recognizes oxyhemoglobin. The oxyhemoglobin absorbs in the blood cell, absorbs this wavelength of light, and that causes some coagulation and closes off these telangiectasias. IPL is also, and we'll get into this later on in discussion, is IPL is also a great way to get rid of pigmented spots, because IPL can, these wavelengths of light recognize these dark spots. It absorbs the energy and then it makes the dark spot go away. So if you go back to here, you can see that melanin and oxyhemoglobin are on that spectrum where that red light is absorbed. And this shows you this that we were talking about, that actually an IPL has been shown to decrease the interleukin 17 on the skin, and we showed in one of our papers that it decreases the amount of interleukin on the eye in dry eye patients. And then we've also shown, and this is one of the studies that we were working in collaboration with our friends in China to show that IPL not only kills bacteria, but it kills these Demodex here. That's music going on here. Turn that down. So we have, in working with my friends, my doctor colleagues in China, we actually now have a way of looking at Demodex around hair follicles and showing what actually happens. Is they like to feed off of dead skin, oil around hair follicles. That's why they're so attracted to moving and migrating to the lid margin. And what we've been able to show is if you hit these Demodex live, that you can actually kill the Demodex with this. So what happens is the IPL is absorbed by these microorganisms, and bacteria destroys their cell membrane and their cell walls, and they die on their tracks. Photobiomodulation. So this process is seen in many areas of medicine where we're using light to stimulate cells to work. So different wavelengths of light have been shown to do different things. So for example, blue light in the wavelength of around 400 is great for killing bacteria, especially acne. So dermatologists use blue light to improve skin. Aesthetics clinics are using intense pulse light to, especially red light, to actually stimulate fibroblasts to produce collagen and elastin to actually rejuvenate skin. Infrared light is used by orthopedic surgeons to actually stimulate cells of the muscle to recover quicker and heal. And all of these processes that I'm talking about are given the term photobiomodulation, that you're modulating the cells to work better. And what happens is when these wavelengths of light, specific wavelengths of specific wavelengths of light hit certain mitochondria, they make the mitochondria work better, and that gets upregulated and the cell works better. And in our studies, and this is something I have a patent for, we find that the specific wavelengths of light that really work to photobiomodulate the cells in the meibomian gland is in that red. So that's why we're putting the filter in IPL, so that we get these red lights stimulating the cells to work better. Even in retina now, they're using infrared light to improve AMD. So it's been shown that infrared actually affects the cells of the RPE to work better. So aesthetics, stimulating collagen, orthopedics, infrared, and then now we know that photomodulation works for dry eye on the meibomian glands. And we're generating heat. So everybody is looking for better devices to generate heat in the dermis, because what we found is if you can generate enough heat in the dermis, you can actually melt these thick secretions, like these toothpaste-like secretions of the meibomian gland, and that allows you to do expression. So one of the things that I have shown and have seen is that after IPL, we generate enough heat to actually open up the opening of the meibomian gland and actually melt those secretions, so it's easy to do expression. Now, the way to look at why you should do expression immediately after IPL is that the meibomian gland is different than most glands in the body. The meibomian gland is a self-contained gland. That the meibomian gland is more like a test tube that is lined by these meibum cells, and we'll see a picture of that after. So what you want to do, if you have the ability to express these glands afterwards, you can actually open up the glands so that the subsequent IPLs that you give these patients can be absorbed. The other thing, and this is what you see in all of these other technologies that do melting of the secretions and actually expression of the secretions, is that once you've cleared the glands of this toothpaste-like secretion, patients will feel better. So this is one of the reasons why immediately after IPL, patients state that they feel better. Where IPL has it over any other treatment, and this is where the Optimum comes in, is that it heats in the dermis above 43 degrees Celsius. Why is that is important is that you need at least 43 degrees Celsius in the dermis to actually melt these toothpaste-like secretions and open up these glands. So LipiFlow, LLT, which I'll get into in a little bit, all of these other type of treatments heat around 43 degrees Celsius. IPL is the only one to get the heat in the dermis to the point where it is higher than 43 and actually even to 50. So what you'll see in these patients, and this is another reason to express, is that it gives you the ability to see exactly how bad their meibomian gland dysfunction. So when it's white toothpaste, that's the most severe. When it gets yellow like this is moderate. And this is a way that you can actually document if the patient is getting better and how the IPL is improving. Another thing that you see, and this is, I've been discussing this right about what's the best way to express. The best way to express a gland is constant pressure. So if you've seen these videos, I give constant pressure. Give the pressure below the test tube and work your way up. Because what it is, this is non-Newtonian physics. So it's physics that is a lot like a tube of toothpaste where you have a bottom, a closed parameters. And when you give constant pressure, that actually decreases the viscosity of the meibum. So if you were just to squeeze really quick, you would only get a little bit of meibum out. But with constant pressure, what happens is the shear forces will decrease the viscosity over time. So you'll get more and more secretions coming out. So you want to squeeze in the bottom of the test tube and then have constant pressure instead of a quick jabbing pressure, because this is the way to get the most amount of meibum, abnormal meibum, out of these glands. So that's the physics of expression. So it's a closed system. You have meibum cells that line this closed system, and this was shown in a paper that what happens in meibomian gland dysfunction is as this meibum becomes thicker and thicker, what you will see is the flow will not go up to the opening, but will go down. And this is why you get closing off of the opening of the meibomian gland. So when you're applying IPL and generating this heat, this actually opens up the opening. And then when you're doing this expression, that changes the direction of the meibum from being produced and going down to being produced and going up. With this information, this is why why you don't see this anymore, but meibomian gland probing doesn't actually make any sense, because you're actually pushing this meibum down even further. So that's another reason to do expression, so that you get the momentum of meibum going upwards instead of downwards. And then what happens after this stage, when the gland closes off and secretions have completely, abnormal secretions have completely filled the gland, that you see meibomian gland shutdown and disappearance on meibography of the meibomian gland, or meibomian gland dropout. So when you're using that in Terrace and you're taking pictures, taking meibography of the glands, and you see dropped out glands, that's because it's gone through these 5 stages to the point of finally there's so much toothpaste there that these glands are dormant. So when you see dropped out glands, it's not that the glands have disappeared, never to come back. It's just that they've filled with meibum, and then the glands just have nowhere else to secrete this abnormal meibum, and then the gland shuts down and it disappears on meibography. But with IPL and series of IPL and getting that abnormal meibum out, you can actually bring these dropped out glands back. So myself and also Dr. Rita Japan have actually, we presented meibomian gland dropout improving with IPL, with optimum IPL, and coming back. So when you see dropped out glands, don't despair, you can bring them back with IPL. And then what do you see on the lid margin in these patients that get IPL? So here's a patient where you see she's losing her eyelashes. You can see these telangiectasias. You see thickening of the lid margin. The glands are dropped out. You can barely see if there's any glands there at all. She's having injection of the conjunctiva. You see bacterial overgrowth, and Demodex have totally overwhelmed this lid margin. Another reason for the disappearance of the eyelashes. You squeeze on these glands and nothing comes out. And this is after 2 treatments of IPL, and you can see the eyelashes coming back. There's no signs of blepharitis. You can actually see normal oils coming out of the glands. Now that lid margin, so here's where the eyelash margin is in the meibomian glands. That distance has decreased because you've actually released all of the abnormal meibum. So why does IPL work? It kills bacteria and Demodex. You get heat expression. It closes off abnormal telangiectasias. You decrease inflammatory mediators on the skin, and you get photomodulation. I believe photomodulation is the #1 reason why IPL is the most effective treatment out there, because you're getting to the root cause of why they have the problem, and you're correcting it and making those cells more normal. Another reason why IPL, and this is going to be, you're going to be hearing this more and more, is that IPL actually stimulates what's called heat shock proteins. The most studied heat shock protein is 70. So applying heat and generating heat to skin surfaces will actually, that do not damage the cells, will produce heat shock proteins, which will actually protect and improve the DNA and RNA processes of cells. So that's why the optimum is so important, is because you don't want to do so much and generate so much heat that you damage cells. You want to do the right amount of energy and heat so that these heat shock proteins are produced and they make the DNA work better. So at the cellular level, you're getting photobiomodulation where you're improving the mitochondria, and then even at the DNA level, when you're producing these heat shock proteins, you're getting improvement of these cells. So it's been shown that intense pulse light actually upregulate heat shock protein 70. This is not the only heat shock protein that is upregulated when you do something like IPL, or this is the reason why CO2 lasers work as well, because it's producing heat shock proteins when you're applying CO2 lasers to the skin. And now there's several heat shock proteins that have been discovered. And again, this is something that you're going to be hearing about more and more in the future. So now there's plenty of papers that show how IPL is great for the signs and symptoms of improving the signs and symptoms of dry eye. The Optimum IPL has the bulk of those papers, and we've been involved in several of those papers. So why the Lumenis M22? So I've been in this for over 20 years. So I've seen from the first generation IPL system, which Lumenis was responsible for inventing IPL and bringing the first IPL to market. And so any xenon flash lamp that produces light is considered an IPL. Where you get into the sophistication of the Optimum is that to be able to treat, and we found that the closer you get to the lid margin, the better efficacy that you're going to get when you're applying IPL. So in these new generations, and this is the latest generation IPL system that's out there, is that it has features that allow you to be able to safely treat the lid margin. So in the earlier generation IPL systems, you're only able to treat around the orbital rim, which decreases your efficacy. That's why you see the bulk of the papers that are showing improvement in dry eye are from the Optimum, because we can get closer. So what the Optimum allows you to do is to pulse this energy at the right pulse rate. And this is my protocol, which you get with the system. The other thing we found in the older generation IPL systems is that we were generating heat, but we were generating heat at the foot plate that we were applying on the skin, and that will burn epidermis. So with the chiller, that allows you to treat without actually doing anything to the epidermis, because you're cooling the epidermis as you're applying this, and the light is going into the dermal layer. So if you look at the earlier papers that I wrote on IPL for dry eye, I would say that you would have to wait 4 to 6 weeks in between treatments, and that was to allow the epidermis to heal. And so with this chiller plate, since we're not actually burning epidermis as we're doing this treatment, you can treat patients every 2 weeks. So the protocol, the standard protocol, is to treat patients for dry eye with a 4 treatment protocol. So with the Optimum IPL system, you can go through a 4 treatment protocol within 2 months, because you're allowed to treat patients within 2 weeks. And in some cases, I've even treated sooner in 2 weeks without a problem. Now, if you did that with another generation, a lower generation IPL system, you would actually do more harm than good, and you would be destroying the skin and the cells of the meibomian gland, because you would not get adequate recovery time of the epidermis. So these technological advances allow you to go through the treatment protocol quicker and safer, so that you can not have any problems with treating around the lid margin, and you get increased efficacy. So right now, we are at about a 99% efficacy in using the Optimum IPL for patients with dry eye. And that is the best efficacy that I've seen reported in any paper that has to do with IPL and dry eye. And this is the work that I have done with a group out in Singapore in looking at the most specific inflammatory mediator when it comes to dry eye, and that's interleukin 17. Another mediator that is very specific for dry eye is interleukin 6. And these are made, both are made by T cells. So T cells make T helper cells, which produce these inflammatory cytokines that we're seeing in dry eye. So if you really want to attack dry eye, you want something that's going to decrease the amount of interleukin 17 in the tear film. And this is a paper we did with our Chinese colleagues that was presented in the American Journal of Ophthalmology, where we showed that IPL with the Optimum, after 3 treatments, decreased the amount of interleukin 17 and interleukin 6. So we see clinically significant decrease in interleukin 17 and decrease in interleukin 6. So this is, to date, I think this is probably the most important paper that we've seen with dry eye, where we're showing that it is decreasing the most specific inflammatory marker on the tear film. And then my biography. So I like doing my biography on these patients to show them their abnormal meibomian glands. And I've actually staged this in our own practice. So a normal meibomian gland, you will see, goes straight up and down. Then the first sign is that you will see that the gland will start to sausage, so that you have these segments in the meibomian gland, and that would be stage 1. Stage 2, that you will see that the meibomian gland will actually Instead of going in a straight line, we'll start to veer one way or the other. Stage 3, you get shortening of the gland, and then finally stage 4, you get dropout. So what I like to do is when a patient comes in, I'll get mybography. I will start the treatments. After the 4 treatments, I will have them come back usually a month later, and then we'll repeat the mybography and we'll show improvement in these meibomian glands. It is very rare that I can't get these dropped out glands to come back. Usually the only time that I've seen where the glands don't come back is if they've had chalazion surgery already, or they've had rigorous probing that has actually scarred the opening of the gland. So this is a phone and this is a phone. This is what I tell people. So you have first generation IPL systems. They can be called IPL systems, but this isn't the same as a 4th generation IPL system. What you'll see here is that so that they avoid adverse events, they'll lower the energy, the pulse width isn't correct, they don't have a chiller plate. There's all these reasons why these are considered first generation IPL systems. And when we're talking about treating the thinnest skin of the body here at the lid margin, you want a system and a 4th generation IPL system. The other thing in terms of first generation and older generation IPL systems compared to Lumenis is that this is a flat top energy level that you're getting. So the energy that you're getting throughout the pulse is what you've programmed. So you don't get a burst of energy and lower energy throughout the pulse width, but you're getting even energy. One of the things in first generation IPL system and older generation IPL systems is the more you use it, the less that xenon flash lamp will give you of energy. So for example, if in a first generation IPL system, if you program 10 joules, when you first get it, it will produce 10 joules. But as the more you use it, the energy level that you get will be less and less. So you'll program 10 joules, but it may give you 9. And then 6 months later, it may give you 8 and then 7. So you're decreasing. And so that's why you see a lot of systems where you have to change these bulbs out and you have another disposable added because they have to give you a new bulb because the xenon flash lamp and the xenon energy is going down. With the Lumenis Optimum, you don't have that problem. This is a very sophisticated system, a large xenon bulb, and so that whatever when you program 10 joules this year and 2 years down the road and you program 10, you're going to get 10 joules, and it's a very even energy level, and that improves the efficacy and the consistency of your treatment. And so this patented Optimum OPT system, the filters and others. So when you get into this 4th generation IPL system, what you're going to find is that it gives you more flexibility in how and what you could use your IPL system for. And so these are first generation systems that really are not that expensive. These are basically $3,000 systems that they've really marked up. And you can see this on eBay. What do these first generation systems have in common? Their energy levels decrease when you use them. There's no chiller. You don't have the ability to change filters. You have no control of the energy levels. And that's important when you're talking about treating different skin types. Since the Optimum has the chiller plate and you can control the energy levels to control thermal relaxation, you're able to use this IPL system on all Fitzpatrick type skin. So you can treat darker skin than I have. So I've been able to use the Optimum on Fitzpatrick 5. I've actually even used it on Fitzpatrick 6. That's for when you get more advanced on what you do. But you need that flexibility, especially if you're in a country where you have darker skin colors. So I would say first generation systems, you can do Fitzpatrick type 1 and 2. But as the more pigment you get, as I showed in the beginning, pigment absorbs energy. So if you try to use these older systems on darker skin, you run the risk of actually burning that skin. The treatment protocols that they have for these systems, they don't have 20 years of experience. So when you get the Optimum, you have my treatment protocols, which have been developed over 20 years and with thousands and thousands of patients. There's no click fee, there's no change of bulb, and we have the most peer-reviewed papers out there. So not only can you use IPL and the Optimum system for dry eye, but you can use it in it has the flexibility to use this in other parts of your practice. So if you have patients with rosacea, you could use the Optimum system the way we use it in our facial aesthetics practice to decrease the telangiectasias and decrease the inflammation on the skin. If you have a patient with chalazion or a hordeolum, you could do spot treatments to these impacted glands, and what you'll see is it can make it go away after a few days. So what I do is if I see a patient with chalazion, I do a spot treatment right on there with the same protocol that I would normally use. Then I do apply gentle pressure to that area, because what I want to do is the flow has definitely been blocked. When you apply IPL, you've opened up that gland. You can do some gentle pressure. You know, they're going to be sensitive, gentle pressure, and just keep some mild pressure on there for a few seconds to decrease the viscosity of the meibum and get that flow going up. So as we know, as these hordeolums happen and these styes and chalazion happen, the flow has gone down. So we want to apply gentle pressure consistently for a few seconds to get the flow going up. And then I give them a steroid antibiotic. And what I found is that you can make these hordeolums go away after a few days. You can use this for acne, rosacea, and acne. You could use it for facial rejuvenation, and you could use it for treatment of spots. This is a patient with acne rosacea, 10-year follow-up, and this is just 1 week after treatment. This patient could barely open her eyes, and after one treatment, she could open her eyes. I've now been treating her for over 10 years. And what's interesting about her is that actually you're getting regression of these this pannus and this ocular rosacea. So this is one thing that has been very impressive to me, that we can actually decrease these telangiectasias. We can treat the upper glands. This is something that we just have written a paper on how you can treat the upper glands with IPL. I do have the patent on light treatments for dry eye disease, and this is when you get into low-level light treatment, where you can use specific low-level light, and this is the Q. And this is the research that I did to bring this low-level light treatment to ophthalmology. There's some people that are trying mask, and I found that doing low-level light treatment with a mask is not productive, and the efficacy is not as good as treating on the skin. And then you see people are using light on the skin, but this is not the right light to use. And this is the way that I treat conjunctivalis, and you could see this on YouTube, but there's plenty of these patients that have conjunctivalis, and I treat them, and this is a video showing how I treat those patients. If you don't treat this conjunctivalis, even if you get the meibomian glands to work better, they will still complain of dry eye, and this is a very simple way of treating the conjunctivalis. And then, as you said before, if you want to improve your cataract and LASIK results, doing IPL prior to surgery. So I do 2 treatments of IPL prior to surgery. And this is my book, which is available on Amazon. And if you want to get a hold of me, you can get a hold of me on social media or email me with any questions. But IPL, the Optimum IPL is the gold standard for treating dry eye disease. It gives you the flexibility to not only treat dry eye, but treat other things in your clinic like rosacea, chalazions. Use it in an aesthetics clinic for facial rejuvenation. Use it to get rid of dark spots. And even though you don't think you're going to get into all of these things, once you get the Optimum system, what you'll find is patients will ask you if you can use this for acne on their daughter or son, or if you can use it for dark spots, or if you can use it for facial rejuvenation. We have an aesthetics clinic in our practice, so when the IPL gets turned on in the morning, either I'm using it for dry eye, or my wife is using it for aesthetics, or the optometrists are using it for dry eye and other things. So it's definitely a system that gets used. So that's it, and I'm available for questions.
Thank you, Dr. Toyos. Before moving to the Q&A session, during which we are going to have Dr. Rolando Toyos and Dr. Alejandre on the line, we are launching one last poll. Do you believe that treating the upper eyelid in patients with severe MGD results in better patient outcomes? I will wait a few more seconds and I will show the results.
This is interesting. So most of you do believe that will make a difference. So the question is, which device can actually you can use and actually do this efficacy and also safely? As Dr. Rolando Toyos mentioned, I think the Optima IPL would be the best solution for this. Welcome, Dr. Alejandre, Dr. Toyos. I would like to welcome you today. Thank you very much for your presentations. They're very exciting, and I believe we have a few questions for both of you from our audience. B, if you're ready.
Yes, I have received one question for Dr. Toyos. Is it possible, and what happens if I treat a patient every month with IPL?
So the good thing about the Optimum with the chiller plate, if you read my earlier articles, I used to say you'd have to wait 4 to 6 weeks to treat somebody. The reason you had to wait 4 to 6 weeks is every time you would apply the IPL, it would actually be burning epidermis. So you would have to allow 4 to 6 weeks for that epidermis to heal to then treat them. With the chiller plate, you're not burning epidermis, you're just allowing that energy level to get to the meibomian gland. So these patients can come back in 2 weeks and get another treatment. So I'm treating patients with a 4-treatment protocol. Usually about 95% of patients go with a 4-treatment protocol. They come every 2 weeks to get their treatment. And I was saying in the lecture, I express after every treatment. And that is helpful to you, especially if you have patients that are traveling far away to come see you. It also helps that you can treat them after about 2 weeks. So you don't have to make a special day for just IPL treatments, and you can actually just intersperse your patients throughout the week. So you don't have to specifically wait 4 to 6 weeks to treat them.
Thank you. I have one question for Dr. Alejandre. Do you believe fluorescein dye is still a good indicator for dry eye disease?
Well, it's certainly useful if you don't have other tools but a slit lamp, but it's not the most reliable nowadays. So if you can use non-invasive BAT, or it's much better. But of course, to see corneal staining, it's still the gold standard. But for mild diseases, I think it's better to do other tests.
Thank you. And I get back to Dr. Toyos for another question. Have you tried osmoprotectant for treating patients?
No, I mean, so the things that we're using the most is IPL. As an artificial tear, I use either oculocin or Optima that has manuka honey. If they have severe nerve damage due to long-standing disease, then I will do platelet-rich plasma. All these things are on YouTube if you want to see it. So I spin blood down to platelet-rich plasma to get nerve growth factor, and I use that as a drop. Conjunctivitis, I think, is one of the #1 things that I'm hearing now. There's several patients that have had long-standing inflammation, and you just see that conjunctiva that's pooching over the lid margin. So every time they're blinking, they're actually blinking on conjunctiva, which is causing irritation and pain and swelling. And that little simple procedure that I showed you using low temp cautery to tighten up the conjunctiva works really well to get that conjunctiva away from the lid margin. So now they're blinking lid to lid and expressing those glands. And then other drops that we have here in the United States, we have T-cell mediators like Cequa, Xiidra, and Restasis. So sometimes we're using those drops. There's some people are using Lotamax, loteprednol, and now there's an approval for a low percentage loteprednol for dry eye. So you may see weak steroids coming back into use. But again, what we want to do is get patients away from drops. And the best way to do that is using IPL, low-level light treatment and low-level light treatment to get the meibomian glands working better and get these patients away from drops. There's no drop that's going to simulate the tear and all the properties that the natural tear has to help patients and their cornea.
Thank you. And they are also asking, what do you recommend to the patient to do at home? Additional lid scrub?
What we do is we do the 4-treatment protocol, and then we have our low-level light treatment that they actually apply right onto the skin at home. We have, and this is LED technology, specific LED technology. We use blue and depending on the patient, if they have more blepharitis, then we'll use blue because blue will kill more bacteria. But blue and red stimulate the meibomian glands to work better in terms of photobiomodulation. So what they'll do is they'll go through the 4 treatment protocol, their meibomian glands will start working better, and then they'll take home a Q and then use low-level light treatment to keep the glands working. And then usually patients will come back any time between 3 months to a year for maintenance treatments with IPL. So when you first get the IPL system, you'll have a few patients, but then your patient population is going to grow because you're not only going to have new patients coming in, but you're going to have patients that are coming in for maintenance IPL. So basically this morning, all morning, I was basically doing new patient IPL and maintenance patient IPL. And now I have patients that have been getting IPL from me for 20 years to control their meibomian gland dysfunction.
Thank you. I move now to Dr. Alejandre. I have 2 questions. One question is, what is your diagnostic protocol post treatment?
Post treatment. Okay, I check the non-invasive boot. I check, but you mean post treatment after IPL or in general?
Pre and post treatment. I don't know if the
pre and post.
Yeah.
Okay. Well, first time they come to the consultations, I do of course the subjective test, normally OSDI, and check how the patient is at that moment. So I do mammography, non-invasive bath, of course, complete exploration in the slit lamp, and with dyeing, lissamine green, fluorescein, and then depending on what the symptoms and what I see in the exploration, I normally will perform an IPL and establish most of the time, because we are a referral center, I will establish also some anti-inflammatory immunomodulatory treatment with normally cyclosporins, I start with corticosteroids and cyclosporin, and then we leave the corticosteroids and keep the cyclosporin. The IPL, I will do it if it's a private patient, because the public system won't pay for the IPL treatment in my country, in Spain. And then I will keep seeing the patient and check for symptoms and non-invasive breakup time. Repeat mammography or not, depending also if I use a treatment to improve meibomian glands, I will check if they're doing better. If not, I won't check in all the visits. And so it varies a lot between private practice and public practice. And I will check the meniscus height, but at the baseline visit, but in the follow-up, not that often. Depends on if there are changes or not, but I normally don't use the meniscus height as a follow-up diagnostic tool.
Thank you.
But it really depends on the patient, because saying you can say the same for all patients with dry eye spacing in a big hospital, because we have a lot of Sjogren syndrome patients, or there's just with meibomian gland dysfunction. We have patients from hematology consultation with a bone marrow transplant. So there is a huge variability in what I have to do for each patient. We cannot hear.
Oh. So what I was going to add to that is that, you know, we have a system too with like Medicare and insurances and things like that. And, you know, most insurances don't cover IPL. But what I do with those patients is I still tell them about IPL. And even though you don't think they may spend money for IPL, so you can start out with drops and other things and tell them, look, if the drop doesn't work, we do have a treatment that actually gets the glands working better to improve your tear film. And if these drops don't work, you could always pay for these treatments out of pocket. So I'm amazed in doing that, what happens is it plants the seed in the patient that there's actually more that can be done. Because what happens to, and this is one reason why we get so many referrals, is that doctors never have that conversation with the patient that there is something like IPL to treat them. So they wind up thinking in your clinic that the only thing that you could do for them is drops. And then they go, well, he never told me about other treatments. So I have this conversation about IPL with all my patients, whether they have insurance or don't have insurance, or just every patient. I say, okay, you've got this problem. We can start you on some medications like Restasis, but just know that there are other treatments like intense pulse light, and then I refer them to a YouTube video, or I give them a book, or I give them a pamphlet.
Thank you for the feedback, Rolando. Dr. Alejandre, is the osmolarity variable, and should it be done in both eyes?
Well, studies have shown that there is no doubt you have to test osmolarity. If you test it, you have to test it in both eyes. It doesn't make sense nowadays to test just one eye. And variability, as I was saying in the talk, it's a hallmark of dry eye disease. So yes, if the patient have dry eye disease, you will find variability in the osmolarity testing. That's for sure.
Okay, thank you. And I'm moving back to Dr. Toyos. Have you thought on serum drops versus PRP versus placenta-based drops?
Yeah, so I was using serum drops for a long time, and then variable efficiency with that and efficacy with the serum drops. And then I started learning about PRP, and the hardest thing about PRP is actually making a stable drop. It doesn't react like a serum drop, and you can see my lecture on PRP versus serum. But once we found the formula for making a stable platelet-rich plasma drop, it is incredible how that drop has improved our results in terms of patients with nerve damage to the cornea. So we're involved with a study with a group out in Boston looking at specular microscopy to determine how we can regenerate nerves with PRP. Now you have Oxervate, which is a purified nerve growth factor, and we've seen some good results with that as well. So you can either go with one or the other, but I think when you get PRP, you're getting 20 times the nerve growth factor is that you're getting for serum drops. And just think about it, when you do serum drops, you get somebody's blood, 50% of that blood is the serum and 50% of that blood is red blood cells. So when you do PRP, basically for every 10 cc's of blood, I'm getting 1 cc of PRP. So you can see the concentration of everything that you're getting, the anti-inflammatories, the nerve growth factor is going to be so much greater. So it's very concentrated. So my patients who have tried serum versus PRP, they've not gone back to serum. I don't even do serum anymore after doing PRP. And if you want to know how to make it, again, I put all this stuff on YouTube. And so I would encourage you to look at PRP.
Also, there is a commercial device that it's already standardized the way to do PRP. So they give you all the things and the protocol, and it's not very expensive. And compared to nerve growth factor, at least in Europe, the difference in price is really, really big. So I will also recommend PRP, yes.
And Dr. Alejandre, after how many IPL sessions you see a decrease in osmolarity?
Can you repeat?
Yes. After how many IPL sessions you see a decrease in osmolarity?
Also depends on the patient, but in some patients you can see it like 2-3 weeks after the second session, but it depends on the patient. But let's say after the second session, if you start measuring 2-3 weeks after, you can see some decrease. But I will recommend to test when you have finished your treatment, and because normally you will have to pay for the test, and the patient would like to see the best results. So the results are better when you have completed all your treatment.
Yeah, thank you. Good feedback. And I have 2 more questions for Dr. Toyos. I invite everyone who has additional questions to write it down. Dr. Toyos, do you have before and after image to share on meibomian gland structure improvement post-IPL? And also, after how many sessions do you see structural improvement?
And just like Alejandro was saying, is that if you're not going to see dropped out glands come back after just 2 treatments, it takes at least 4 treatments, and sometimes it can take 5 to 6 treatments to actually see dropped out glands coming back. Now, if you have a stage 3, 2, or 1, you definitely can see improvements. So 10 years ago, I presented at Escaris the photos of meibomian gland improvement on meibography with IPL. And then 3 years ago, Dr. Rita out of Japan presented her results of using the Optima showing improvement in meibomian glands. So if you think about the lecture that I gave, not only are you improving the meibomian glands at the cellular level, but with heat shock proteins, you're improving the glands on the DNA level. So this is a very highly sophisticated treatment for meibomian gland dysfunction. So I never subscribed to the dropped out gland theory that these glands were scarred and needed probing or something like that. I just have seen over the years so many patients that have glands that were not functioning at all after several light treatments and photobiomodulation that these glands came back. And that's when I got convinced that photobiomodulation was the #1 reason why these patients were getting better, and not so much that we're generating heat or expression or closing off telangiectasias or decreasing inflammation, that there's actually something going on at the mitochondrial level when we're doing these IPL treatments. And this is borne out in several different specialties in orthopedics, in aesthetics, in plastic surgery, in dermatology, in retina, that photobiomodulation is real, and you just have to discover the right wavelength to stimulate the mitochondria.
Thank you. I have one more, the last question for Dr. Alejandre. If the patient does not have symptoms, but osmolarity is still high, do you continue the IPL session?
If patient doesn't have symptoms, but osmolarity is high.
Osmolarity is still high, yes.
Also, it depends on the rest of the exploration. If you have a neurotrophic problem, for example, like Dr. Toyos was saying, the patient might not have symptoms, and the cornea might be really in a real bad condition, and their osmolarity, if no one have seen the patient before, but it will have helped to discover that patient. It really depends on the rest of the exploration. So without, you can have dry eye, even severe dry eye without symptoms. So you have to check not only symptoms, and if the osmolarity is wrong, normally you will find something wrong. It's true that, and a recent study has shown it, that it's true that osmolarity can appear before other signs. So normally, if it's possible, you will need to do a follow-up of the patient. And if everything is okay and osmolarity is wrong, I will do a follow-up. The patient will need to be seen, let's say 6 months or a year after, but you have to check if there are other things, because normally you will find other signs of dry eye.
Thank you very much.
So I would, and there's patients that, and when you develop your clinic, you're going to get some outliers, but there's a group of patients out there that have mixed mechanism dry eye. And two things on the osmolarity thing. So you get their improvement of their meibomian gland dysfunction with IPL, and they're still having problems, then you have to start looking for other things. So we talked about, and Dr. Alejandre did a great job talking about the other things that he's seeing. But what I'm seeing now, since I'm a referral clinic, is you'll have some patients with an anatomical problem that you've fixed their meibomian gland dysfunction, but they have some type of anatomical. I got a patient that was born, he's Asian, and his lids look like this, so he's got an open gap. So even though the meibomian gland dysfunction is improved, we have to fix that anatomical problem, and that could give you an abnormal osmolarity. Or a mixed mechanism dry eye patient that you may not think they have a problem with their lacrimal gland. You've gotten the meibomian gland dysfunction taken care of. Schirmer's might have been normal when you started this process, but they might have a little bit of a lacrimal gland problem too that could be giving you an abnormal osmolarity. So there's a group of patients that is very simple to take care of with their meibomian gland dysfunction, but then you're also going to have that small group of patients that things are a little bit more complex. And that's why I'm doing more conjunctivalis surgery now, because I've realized that some of these patients have had such long-standing dry eye that it's really changed the anatomy, and that we have to start doing some other things to completely get these patients well.
I do have a question. After doing surgery in conjunctivochalasis, because how many patients you'll say find a great change after that?
Patients, I mean, that is the last thing. So I do IPLs first to see if that conj will come back up. So they go through the 4 treatment protocol, and then I give them 1 month off just to see if the conjunctiva will come back. And then if the conjunctiva doesn't come back, then I do conjunctivalis. And a lot of times that's the final piece of the puzzle to get these patients better. So you've gotten the meibomian gland dysfunction corrected, Their tear film is better. They're still having some symptomatic problems. You do the conjunctivalis surgery, and that's the final piece of the puzzle. I mean, I've had patients just go, oh my gosh, this is the difference between night and day. But you do have to do the IPL first, because some of these patients, the conj will come back just after doing IPL and giving them some relief with the meibomian gland dysfunction. And I've tried
because I normally only do surgery if I see the conjunctiva over the, I mean, a really big conjunctiva, but with small ones, I normally don't treatments, but I may change my opinion if you find it's really worth it.
It is worth it is worth it, because you're only seeing them in one moment of time, and the problem is your dry eye patients will tell you, yeah, oh, this is great, I've been great, and then they'll also tell you times when oh, it's not so good, you know, and the conjunctivalis could be a little bit worse in a day that you're not seeing them. So if you even see a little bit of conjunctivalis that's starting to overlap in the lid margin, now it's not where the meibomian glands are, that's somebody that I would treat.
But you do need to see it overlapping the, so at least overlapping the border, no?
If I've done the IPLs and their meibomian gland dysfunction is taken care of and they still have conjunctivalis, that's not going to get better. It tells me it's not going to get better, and then they're going to be spiking. Some days it's going to be a little bit better, but some days it's going to be really bad. And I've seen that too, where I've told a patient, oh, you don't need conjunctivalis surgery, it looks good, and then they'll come back and they say, oh, I'm having a real bad week, and then I'll look at the conjunctivalis and it's worse. So if they have conjunctivalis after you've gotten their meibomian gland dysfunction better and it's still there, then I would just treat it. I'm more aggressive. If you ask me one thing that I'm more aggressive with, that's the number one thing in the last 2 years. I'm more aggressive doing conjunctivalis. And it's a very simple procedure. Patients don't even wear a patch afterwards. And you're not doing much. You just do a little bit of low temp cautery after you've given them a lidocaine injection. You can see the video. Just a little low temp cautery, and it just sucks back in. They don't even wear a patch. They go home.
No, it's easy.
Thank you. Thank you
That's
very
it,
much.
yeah.
I have one last question for Dr. Toyos. I think it will be the last one for today. How do you compare IPL treatment to vector thermal pulsation technology?
So thermal pulsation is only giving you heat and expression. It's not doing any photobiomodulation, so it's not doing anything to stimulate the cells to work better. You may get some heat shock proteins doing it, but we did thermal pulsation in the beginning and tried it, and again, I think it gives some temporary relief, but if you really want long-term improvement in the function of the glands, then it has to be IPL. It has to be IPL. And then low-level light treatment, this cue that I'm showing you, this is only for maintenance at home. I mean, the energy level that my cues generate are 1 to 3 joules, not 10 to 16 joules. So I put IPL here, I put low-level light treatment here, I put thermal pulsation. It's not even on the screen, no. I put thermal pulsation right about there. So it's a good maintenance and it will help. It's better than a warm compress, but IPL number 1, low level number 2, thermal pulsation number 3.
Great. I want to put a big thank you for both panelists. That was a great content. If we have any more questions, we'll send it to you. Maybe you can answer that via email. We're kind of running short of time. So thank you very much for your time, and thank you for your great presentations.
Yeah. Thank you.
Bye-bye.
Thanks, guys.
So we're going to continue our session with our market business development manager, Beatrice. She's going to talk about the package, the marketing package that we actually tailor-made to the doctors in order for them to be able to promote the treatment to the patient. I think this is an invaluable tool that will help you actually educate and increase awareness to your patients. The floor is all yours.
Mute, sorry. Thank you, Paris. Hi, everyone. I am Beatrice Blasi, and I am the Marketing Development Specialist for Lumenis Vision. EMEA, I cover and I work with Paris for EMEA. And I will introduce you the after-sales support that we provide to our customer. We have recently created a new portal for you, and this is the Partner Zone portal, through which you can access different material that can help you in your practice. Starting from next week, we are going to send also to the actual customer, because the portal has been launched last week, an email, and so all the new customers starting from next week are going to receive this email with a link that will give them access to the Partner Zone portal. In the Partner Zone portal, apart from the clinical study and the training video, you will be able to find two important items that will help you to awareness the Optima IPL solution for treating dry eye to your patient. And the first package is the toolkit. It contains different material that you can download and print. You can also personalize it because it gives you the option. There is also the open file that gives you the option to include your own logo. And it contains trifold, roll-up, poster, brochure. There is also a nice waiting room video that explain, especially made for patient, what dry eye is and how IPL can treat this the dry eye disease. And this is very well done because not all patients are aware about IPL treatment, and this is it explains very well how the IPL can help treating dry eyes. The second support that we provide you is the digital toolkit. During especially those last month, we know how it was important for the doctor to communicate with their patient online through the social media, via email or on their website. So we have created some specific banner that you can reshare and use on your media. And we have also created for you an email to keep you updated with the latest news, with the last marketing material and new clinical studies article. And this email will be received once per quarter. So each quarter we're going to share with you the email. I also invite you to visit the Lumenis Vision blog. It's a blog that we have launched during the pandemic time. And in this blog, you will be able to find some tips from our KOL about dry eye and IPL. And I also invite you to follow us on our social media to stay updated for the upcoming event and project that are following soon in the EMEA country. And that's it from my side. If you have any particular request or question, you can contact me through the email. I also would like to hear from you if you think that we are missing something or that we should support in some other way. So thank you very much for your time. And I hand over to Paris because now we are going to launch the Lumenis quiz, and Paris will explain you how it's work. Thank you.
Thank you very much, Bea. That was very helpful. One thing that I also wanted to say that all the content that you have watched today will be recorded, and you will have access to it. Also, if you visit our virtual booth, there is a webinar room that we have a lot of recorded webinars, and you can access them at your leisure. Again, I think it would be interesting for you to actually come into the virtual booth and interact with the system, download any content you want, and of course have a real-time chat with all of us at any time you want. So, as we said in the beginning, we're going to wrap this up by also having a quiz. Bea, if you can put the screen up. We can show you. Okay. So until Bea gets this ready, you know, in the spirit of the holiday season, we're gonna give out some token of appreciation from us. All you have to do is to answer one question that we're gonna show you right now. The first 3 correct answers to this question, they're going to receive a gift card from Amazon that you can give to loved ones, or you can buy something for you. All you have to do is send your answer to email emea.vision@lumenis.com.
Sorry, I think the presentation is cut, so I don't think they are able to see the whole screen. So let me try to fix it before we launch the quiz.
Maybe you can leave it like this. I mean, you can see the whole slide now. It's not presentation mode. We can still see it.
Okay, yes, I think it's better because otherwise it will be cut. Let me know when you want me to move to the next slide. Okay, we are going to launch the question.
Okay, if you have to scroll it a little bit, yeah. Okay, so the question is, how do you treat meibomian gland dysfunction and ocular rosacea with IPL in order to maintain clinical efficacy and at the same time eliminate potential side effects for the patient? Number 1, do you utilize Lumenis optimum pulse technology that guarantees a uniform top hat effect by delivering without spikes? B, engage the chilled sapphire tip on the Optima handpiece that keeps the skin surface cool. C, pulsate the energy, meaning using a triple pulse, by taking advantage of the thermal relaxation time of the tissue so that you can deliver the energy needed, but without burning the patient. And D, all of the above. We're gonna leave the answers for a few seconds. And again, you send the correct answer to emea.vision@lumenis.com. The first 3 correct answers will get 3 gift cards. So Concluding, I wanted to thank you all. First of all, I want to thank our panelists for a great content. And thank you, all of you, for your patience and your time, both from yesterday and today. We do hope that you enjoyed this session. We're open with your comments, how we can make this even better and more interesting for you. Again, we have the virtual booth launch is going to be ready and open. So all this material is going to be available for you at any time you want to access it. Also, we're going to be also available for any questions you might have. Wish you all the best. Thank you very much and have a happy holidays. Thank you.